So good afternoon. Actually, it's a pleasure to see the hall to be quite full even on the penalty, the last session of the day. So Dr. Shilpa has already covered briefly about the appearances of breast cancers in young. So I'll be briefly touching about the pregnancy-related breast cancers. So coming to the definition of PABC, we'll go through the clinical presentation and the role of breast images. We need to understand the physiological changes that occurs. So there is more of ductal proliferation and lobular growth during pregnancy, which leads to increased vascularity and reduction in the stroma. The fat and fibrogranular tissue vary among women, but not between both breasts of the same woman during pregnancy. Um, During pregnancy, the hormones they come into play, and during the first trimester, it is estrogen which causes ductal proliferation as well as alveolar growth. During the second and third trimester, progesterone comes into play, leading to lobular hyperplasia with involution of fibrofatty stroma. The physiological changes manifest clinically in the form of increased breast size, the breasts become more firm and nodular, and this persists throughout lactation. Following delivery and lactation, the placental estrogen and progesterone levels fall, the prolactin and oxytocin increase, and it returns to baseline 3 months after cessation of lactation. Pregnancy-associated breast cancers are the cancers that occur concurrent with pregnancy or within 1 year of delivery, and the incidence ranges from 0.2 to 3.8% of the breast cancers in women. But a few recent studies have shown that it has to be further subdivided with breast cancer that occurs during pregnancy, and it also has to be divided into postpartum breast cancer, so with suggestions that range from between 5 to 10 years post-delivery. And almost 35 to 55% of the breast cancers occur within 10 years of delivery, so that will a separate classification has to be made. And the median age at diagnosis is around 34 years, and there is always some association with BRCA1 mutation. And the delay in diagnosis ranges from 1 to 13 months in case of pregnancy and lactation. Clinical presentation is becoming more common because ladies are conceiving later in life now, and usually presents as a painless mass with unilateral breast enlargement. Skin may be thickened, there can be localized pain. Patient may present with pathological nipple discharge or metastasis. And following delivery, milk rejection is a very common feature if we obtain the history. It means the infant is reluctant to suck milk from the affected breast. And if any clinical symptoms last for more than 2 to 4 weeks, imaging is always essential, but we have to remember that almost 80% of the breast lesions during pregnancy are benign. The reasons for delay include lack of awareness about breast cancer in young women, about which Shilpa has already told extensively. There is reluctance to seek medical attention. The patient will be busy caring for her baby rather than caring for the problem in her breast. And a delay in diagnosis can be attributed to the hypertrophy of the breast tissue during pregnancy and lactation. And this can mask the symptoms, leading to reduced sensitivity of clinical examination. And again, inexperienced obstetrician or midwife, they also will say, okay, it's a benign lesion, don't worry about it. And patient always denial comes into picture. High-grade invasive mammary carcinomas can occur with lymphovascular invasion. Lymph node involvement directly influences the survival. And most of the cancers during pregnancy and lactation are hormone positive and they fare relatively better. But 30% of them were hormone negative as well as HER enriched. And the larger tumor size, late diagnosis, and leads to worse prognosis. And it's associated with lower overall survival and disease-free survival as compared to non-pregnancy associated breast cancers. Once a breast cancer has been diagnosed, we have to do a thorough clinical examination with imaging as followed by biopsy. So clinical examination, we have to see if there is erythema, there is swelling, bloody nipple discharge, presence of local or distant metastasis. Breast ultrasound has to be performed, including a thorough examination of the axillary region. The detection of malignancy in pregnancy, ultrasound has got a sensitivity of 80% and specificity of almost 88%. Mammography needs to be obtained. It can be either a single or two view. It's mainly to assess the tumor extent, multifocality, or bilateral disease. And contrast-enhanced breast MRI is usually omitted during pregnancy. Once malignancy is confirmed, we need to do a metastatic workup, especially if it is breast cancer in a high-risk lady, or she has got clinically positive or imaging positive axillary lymph nodes. The tumors of more than 5 centimeters in size, that is T3 masses at presentation, And the tumors with aggressive biology, or if the patient has got any clinical signs, symptoms, or lab findings suggestive of a metastatic disease. So how do we do the distance staging in a pregnant or lactating lady? Ultrasound and MRI are preferred, and whole body diffusion MRI is useful to detect skeletal, liver, and peritoneal metastasis. CT as well as PET CT should be performed in a pregnant lady only when the benefit to the mother outweighs the risk to the fetus, and that might result in the change in plan management. So ultrasound has got a high sensitivity with a negative predictive value of almost 100%. Initially, if she has got any clinical concern, a targeted ultrasound needs to be performed. If it is suspicious, then scan the same breast for multifocality and also the contralateral breast. And typical BIRATS features may not be present, and any lesion, if it's suspicious, always proceed with biopsy. On ultrasound, usually we get large cystic parts due to the invasive nature and central necrosis. Any complex solid cystic mass which is discovered during pregnancy and lactation, it should be biopsied and should not be abandoned to be an abscess or galactosele unless clinically apparent. The parallel orientation and posterior enhancement were present in almost 60% cases of the pregnancy-associated breast cancer. So the benign-looking masses are not actually benign in almost more than 60% of the cases. This is a 23-year-old lady who was 8 weeks pregnant. She was a medico, and she presented with a left breast lump. Ultrasound was performed that showed a suspicious mass. The lymph node was apparently looking normal. So it was an irregular non-mass area with marginal vascularity. Core biopsy was performed that confirmed invasive mammary carcinoma luminal A. And since this lady she was quite aware of, she opted for an MTP with mastectomy. We actually offered breast reconstruction for her, but she told, no, I just want it out. And she was having micrometastasis at diagnosis. And this was another 36-year-old lady, 2 days post-delivery, who had presented with a right breast lump. So it was a complex solid cystic mass with intralesional vascularity, and this lady had never palpated her breast throughout the pregnancy. So immediately after delivery, when she couldn't feed the baby properly, that time only the lump was diagnosed. So core biopsy showed triple negative with the lactational changes, and she also went ahead with an MRM and with central lymph node biopsy since the lymph nodes were looking normal. And we should know that during, usually the surgery is done post-delivery only, and sometimes if the lymph nodes are looking normal, they don't proceed with central lymph node biopsy. And this was a 30-year-old lady who was nursing a 7-month-old infant presented with a left breast lump. So again, complex solid cystic mass, the cystic component was really big, and with an axillary lymph node that was looking suspicious. So core biopsy showed invasive mammary carcinoma with a high-grade associated high-grade DCAS. Again, this was triple negative with proliferative index of almost 90% with lymph node metastasis. A 43-year-old lady with a left breast lump, and she was currently nursing a 10-month-old infant. So this is what we had found out. And again, it's a mass, suspicious mass in the left breast, and her axilla was also showing mass with irregular margins, suggestive of extranodal spread. And core biopsy showed invasive mammary carcinoma. This was a HER-enriched tumor, again with a high proliferative index. Another 27-year-old lady who was full-term pregnant and was recently diagnosed with acute lymphocytic leukemia. She was on treatment, and she presented with a right breast lump. So we found out she was having lesion not only on the right but also on the left side. We proceeded with biopsy, and this turned out to be ALL deposits in the breast. So unfortunately, it has got a very bad prognosis, and this patient could not live long after the diagnosis. So imaging mammography is a safe method during pregnancy. So abdominal shield reduces the radiation by almost 50%. And like Shilpa has already told, the breast dose is less than 3 milligray, the allowable limit, but the fetal radiation is less than 0.03. But mammography is indicated only in clinical and imaging suspicious lesions or biopsy-proven malignant lesions. It has got a sensitivity of almost 78 to 90%, and mammography alone shows the microcalcifications, multifocal as well as multicentric lesions. And the imaging features that are seen on mammography are similar to the non-pregnant lesions. This was a 30-year-old lady with a 2-month-old infant. She had presented with a right breast mass. The size at presentation was more than 10 centimeters, and this turned out to be an invasive mammary carcinoma grade 2 luminal B type. And ultimately, she proceeded with mastectomy with axillary clearance. This was a 36-year-old lady with a 3-month-old infant and who had presented with a right breast lump, and she has very recently stopped lactating. FNAC was performed elsewhere, and that was suspicious for malignancy. We got a mammography done initially, and we can see that it's heterogeneously dense. If you closely observe, so she has got a global asymmetry on the right side, and also the left breast shows lactational changes. So on history, she told the child was not feeding at all from the right side. So this is how a typical mammography suggestive of a milk rejection looks like. So one side she is feeding, the other side the baby refused to take feed. And the digitally magnified view shows presence of calcifications that could be seen only on mammography. And these are the ultrasound images. It was a mass, and she had lymph nodes that were reactive actually. So she was given NACT. She subsequently underwent mastectomy in view of the initial large size of presentation. And she had residual disease, but lymph nodes were negative. A 36-year-old lady had presented with a lump of 7 months, and she was currently nursing her 10-month-old infant. And mastitis was suspected, and repeated aspirations were performed. She was given antibiotics. She had no relief. And when she was referred to us, this is the appearance that she had, a mass in the right breast with enlarged lymph nodes. So ultrasound showed a mass with irregular margins, and it's quite vascular, and the lymph nodes were hyperemic. Core biopsy showed invasive mammary carcinoma, triple negative, again with high proliferative index. But again, for her, the lymph nodes were, FNAs of the lymph nodes showed reactive lymph nodes only. But in view of the initial lesion size at presentation, and especially the T3 lesions, we do go ahead with an auxiliary sampling. For MRI of the breast, contrast agents are not recommended during pregnancy, but it can be performed safely during lactation. Breastfeeding should be performed just before the scan, and it's preferable to withhold for 24 hours post-scan. Background parenchymal enhancement is expected, but it is not seen to affect detection of rapidly enhancing masses. And in case of biopsy-proven neoplasm during lactation, MRI helps us to know the exact extent of the disease. This was a 36-year-old lady delivered 3 months back, and she had a right breast biopsy-proven malignant mass, and she wanted breast conservation. So mammographically dense breast, since you're planning, and it was a necrotic mass, since you're planning a conservation, we went ahead with an MRI breast. And again, showed a unifocal mass, again, it was necrotic, so she went ahead with a breast conservation. This was a 39-year-old lady, is elderly primigravida, and she was she had a 3-month-old child when she presented with a left breast lump. So ultrasound was performed elsewhere that showed a necrotic mass, and she was referred to us. So we went ahead with a diagnostic mammography, and what is very obvious is definitely it's a dense breast. We can see the mass, but we can also see some calcifications, suspicious calcifications. So this is the mass. Actually, it's a nice necrotic mass, and MRI was performed for her. That again showed it's really fully necrotic. Only a thin rim was left. So MRI also helps us to guide our biopsy. So in case if we are taking biopsy from the center of the lesions, we may be missing out the viable tissue. So usually in these cases, that pre-procedure MRI helps us to guide the biopsy so that we get viable tissue. And the non-mass enhancement that we see on MRI breast is actually corresponds to it's much extensive and seen to lead almost up to the nipple. This lady was very, very desirous of breast conservation actually. And this was in the lower outer quadrant. And mammography also showed an area of architecture, tomo also showed an area of architectural distortion. So ultrasound showed a mass in the upper inner quadrant, so almost close to the sternum. And MRI also showed a suspicious area, and biopsy was performed from two diagonally opposite areas, that is from the upper inner quadrant as well as the necrotic mass. And this was an invasive mammary carcinoma grade 3 luminal B, and again with high proliferative index. It was hair enriched also. At the same time, on right side, we could see that again she had some subtle architectural distortion with calcifications. This we wouldn't have, and this was non-palpable. So if we had not done a tomo, definitely would have missed this lesion. So suspicious mass again, and this was an invasive mammary carcinoma. This was luminal B, again her enriched, and here the proliferative index was slightly low. So now this patient was put on NACT, and what is important is the surgeon was able to plan the treatment beforehand itself. So we have decided to do a mastectomy for her on the left side with LD flap reconstruction. And right, since the calcifications were there, we were planning to do a wide local excision with grade 1 oncoplastic surgery. So it helps a lot to plan the surgery before the patient goes on treatment. So just to show, a 29-year-old lady who was 30 weeks pregnant in 2017, and she had presented with a right breast lump. So core biopsy was performed. It was triple negative breast cancer. She opted for breast conservation surgery. So NACT followed by lumpectomy was performed. So later on, she was on follow-up, and next year she came for the first surveillance mammography post-RT. But because of COVID, she lost out, and then again in 2021, she presented with a mass in the left breast. So what happened was we performed a core biopsy of the suspicious mass. She was having lymph nodes also. So this was an invasive mammary carcinoma grade 3 luminal B. So earlier one was triple negative during pregnancy, and after that the interval mass was luminal B type. So and it was only a local lymph nodes were positive, local metastasis, and PET-CT showed local regional disease, and she underwent NACT. But by the time we performed her BRCA testing, she was positive for BRCA mutation, and she subsequently opted for bilateral MRM. So ultrasound and mammography guided procedures can be performed safely during pregnancy and lactation. MRI guided biopsy can be performed during lactation. So local anesthesia is absolutely safe. There is always an increased risk of bleeding and infection, and rarely milk fistula formation can occur. So while taking a consent, we specifically have to mention this. So ACR appropriateness, it says that breast for screening can be safely done with mammography during lactation. And in a high-risk lady who is less than 30 years of age, again breast cancer screening should be continued during pregnancy also. And breast cancer screening during pregnancy in an intermediate or high-risk lady between the age of 30 to 39 years can be performed. And above the age of 40 years, any pregnant lady, ACR is recommending that we have to proceed with initial imaging with mammography. Screening can be safely performed. In a diagnostic setting, pregnant women with palpable lump, initial evaluation has to be done with ultrasound, followed by mammography if necessary. Pregnancy with suspicious nipple discharge, always perform a diagnostic study. And locoregional staging of newly diagnosed breast cancer during pregnancy, we have to use mammography as well as ultrasound. So the take-home message is most pregnant and lactating women present for breast imaging have benign breast disease. Thorough breast examination is a must in antenatal visit. For here, we were having some issues in India, like our gynecologists, they do the scanning also. They do all the antenatal scanning. So now they are saying, okay, let us do the breast scanning. So I really don't know how it's going to work out. Like if the gynecologists, they start doing the breast ultrasound, I don't know what the picture will be. And we have to evaluate all palpable masses that persist for more than 2 weeks or longer with ultrasound, and biopsy any new solid mass, even if they're benign looking. If no biopsy, inform the patient well, a close imaging and clinical follow-up is a must. And even if no abnormalities discovered on ultrasound or mammography, biopsy should be performed from the region of persistent palpable nodularity or thickening. So these are the references, and thanks for patience.